Good afternoon. Welcome to the PAA Clinical Training Series. Today's topic is Person-Centered Service Planning. My name is Alicia Hollinger. I am the Clinical Operations Manager in the Division for Community Living at the Ohio Department of Aging. Today's agenda includes Person-Centered Service Planning, also known as PCSP, PCSP signatures, documentation, and best practices. What is person-centered service planning? We're going to open up with a few rules that are very important to the person-centered service planning approach. According to the Code of Federal Regulations, which is cited at the bottom of the slide with a link, this is the definition of a person-centered service planning. The person-centered service plan must reflect the services and supports that are important for the individual to meet the needs identified through an assessment of individual functional need, as well as what is important to the individual with regard to preferences for the delivery of such services and supports. Next, we have our state rule. Nursing facility-based level of care, home and community-based services programs. This is the person-centered planning rule. This is an Ohio Department of Medicaid rule for Ohio NIF-based waivers regarding person-centered service planning. This rule details the items from the federal rule regarding waiver individuals and the need for their care planning and service planning to be consistent from a person-centered approach. And as you can see, the link below, it's the Ohio Administrative Code 5160-4402. And that link will take you to this rule. The person-centered service plan, waiver individuals receiving HCBS services lead the person-centered service planning process. The individual and/or their family develop this person-centered service plan with the case manager, outlining their person-centered goals, objectives, and interventions. It is the responsibility of the case manager to ensure the person-centered services plan reflect service authorizations given, including any changes to service provision. The person-centered service plan is composed of the care plan and the service plan in PIMS. So as you can see below, the care plan plus the service plan equals the person-centered service plan. The care plan. The care plan is developed during the initial assessment, enrollment process, and reviewed with the individual no less than quarterly. The case manager updates the care plan as needed with the individual. The care plan includes all formal services, informal, and gratis services, and each service should have the payer source noted. This includes Medicare services, state plan Medicaid services, including private duty nursing or home health aid, and of course, waiver services. The care plan is sent to all providers at least annually. If there is a change to a specific service at any time, the care plan report is sent to the applicable provider or providers. So again, we like to note the PIMS system does not allow separation of the care plan report by service or provider. So moving on to the service plan. The service plan is also developed during the initial assessment and reviewed with the individual no less than quarterly. Quarterly is our contact schedule for Passport. The service plan report does not necessarily get updated every time a care plan is updated. The service plan report includes formal services, informal, and gratis services. Each line should have the payer source noted. This includes Medicare services, state plan Medicaid services, private duty nursing, or home health aid, and of course waiver services. The service plan report is sent to all providers at least annually. If there is a change to a specific service at any time, the service plan report is sent to the applicable providers. And again, we like to note the PIM system does not allow the separation of the service plan report by service or provider. So here we are moving on to the person-centered service plan and including private duty nursing expectations. So again, we have cited the 5160-4402 rule, which is person-centered planning. That is an Ohio Department of Medicaid rule in which encompasses all of the NIF-based waivers, which we are included. So we want to move on and also include Rule 5160-12-02.3, which is private duty nursing procedures for service authorization. And this is a link you can click through to see the rule. Basically, the PDN services are approved for individuals as a result of an in-person assessment or reassessment by ODM or designee. This process is currently under revision and will be communicated to the PAA. So the actual process for how someone gains PDN nursing services is still under revision with ODM. But at this time, when someone has a waiver and they have a case manager, the case manager is responsible for all of the services being on the authorization, which is the service plan report and the care plan. So if someone does not have a PDN nurse on an individual's care plan or service plan, the nurse can be called to repay the money that he or she earned while providing services. Sometimes this happens when there's a review, and oftentimes the review could be 4 or 5 years down the road, and then someone is asked to repay money. So it's very important. When we get the update, we will let you know and make sure that we have as much information as possible to share with the PAAs. So the person-centered service plan oversight, this kind of leads into the previous slide. One example of external auditing is SIRS, which is the Surveillance and Utilization Review section at ODM. And as I earlier said in the previous slide, the example of the RN that was told she needed to repay money because the service plan report was not accurate. So this is why we want to make sure that this is a priority for our case managers. All auditing completed by entities internal and external to the state utilize the PCP to ensure services billed by each provider are supported through authorization, documented in the PCSP. This means the care plan and the service plan report. Include all non-waiver services, including third-party insurance, Medicare, Medicaid, state plan, skilled services, and/or private duty nursing. Ensure all the services and payers are included on the care plan and service report, including those in which ODA waiver doesn't pay directly. So again, I've got the bullet point. When audits are conducted by various entities, if a service is not listed on the ODA PCSP, the auditing authority may find the provider's payment to be unauthorized and force the provider to return the money. Signature requirements. Person-centered service planning signatures pertaining to individuals. The individual is required to sign when the PCSP is initiated, modified, or updated. Acceptable signatures include, but are not limited to, handwritten signatures, initials, or stamps or marks, or an electronic signature. This second bullet actually comes from Rule 173-3901 of the Ohio Administrative Code, which you'll see is below, is linked, and it is the definition of a unique identifier. So that's where the rule houses this information stating what a signature can be as long as it's noted properly in the care plan. Any accommodations to the individual's or authorized representative signature shall be documented on the care plan. A signature is required when a new service is authorized an existing service authorization is adjusted and anticipated to continue for the duration of the service plan, or a new service plan report has been issued. So our example is a signature is not needed if a case manager approves an additional 10 hours of services the first week after an individual has had a NIF stay or a hospital stay. So now we're going to cover the person-centered service planning signatures from the provider side. This is from guidance issued by CFR in October of 2018. Waiver service providers are required to sign the individual's person-centered service plan meeting requirements in Rule 42 CFR 441.301, requiring the service plan report to, quote, be finalized and agreed to with the informed consent of the individual in writing and by all people and providers responsible for its implementation, unquote. So we know the providers may sign the PCSP in person, electronically, or by mail. The signed PCSP must be returned to the provider by the provider to the PAA. A signature is required when a new service is authorized and existing service authorization is adjusted and anticipated to continue for the duration of the PCSP, or a PCSP has been issued. Only the provider affected by the change needs to provide a signature. Documentation. PCSP signatures individual documentation. PIMS does not currently have the capacity to capture an electronic signature. The case manager is responsible for providing a copy of the individual's PCSP to the individual, as well as obtaining a signature. The case manager will review and update the PCSP at in-person quarterly contacts. The case manager will maintain a physical document dedicated to obtaining the individual's signatures agreeing to the PCSP. So that should correlate. If you go out and do a visit today, you would make changes in PIMS indicating that today's date was when the care plan was updated, and if an individual signature is required, you can have them sign this physical document to ensure that that was their understanding as of the same date. So this document will include the individual's name, signature line, and date of signature acknowledging the PCSP. PCSP signatures, provider documentation. PIMS does not currently have the capacity to capture an electronic signature. The case manager is responsible for sending a copy of the individual's care plan and service plan report to the provider or providers for signatures. The case manager should note in case notes the day the PCSP was sent to the provider or providers and the deadline for the signature to be returned. The case manager should repeat this process up to 3 times per provider. Documentation and case notes should reflect this process and the follow-up process. Home and community-based settings. PCSP, home and community-based settings. So we need to ensure case managers understand the HCBS settings. A training will be provided in the near future regarding additional information about HCBS settings. So as we know, all HCBS setting modifications must be in the care plan for distribution and a signature from the appropriate providers. Care plans should include a separate goal addressing the following: HCBS settings care plan with a general statement regarding modifications. This care plan should state if the individual does or does not have modifications. Each HCBS setting modification should be in a separate care plan with details, including dates of changes. And again, I have attached the link to the settings rule, which is in the Ohio Administrative Code 5160-44-01. Care plan examples. First, I'd like to talk about the examples. I want to provide a disclaimer about the names. Some of these examples are actual care plans. I changed the names for anonymity. The reason I have the names instead of consumer or individual is that past CMS guidance has indicated they want to see the person's name. Again, this is another example of personalization and person-centered service planning. All right, so let's talk about the first example, which is for Jane Doe. The implication is the HCBS settings rule. See how they document it and actually use that terminology? I think that's very helpful for CMS for further reviews or additional reviews, that it will jump out and they will see that this is indeed a settings rule care plan. Jane Doe attends adult day service and requires modifications to the rule due to wandering behaviors related to her diagnosis of dementia. Less restrictive interventions have not met Jane's safety needs. Again, adding that last line about less restrictive interventions have not worked is also in line with the HCBS settings rules. It indicates that we are at another step above the less restrictive intervention because the less restrictive intervention has not worked before. So we go to the intervention. The HCBS settings rule criteria will be reviewed annually with any changes in condition and as Jane requests. CM will share the person-centered care plan with the ADS settings provider. So then we have the goal. Jane will have supervision while at ADS as a modification to the home and community-based settings rule to ensure her health and safety needs are met. The door is also locked to prevent wandering. She will have the least restrictive environment possible while at ADS. So again, it's a great care plan. It's talking about the least restrictive, but I did highlight the sentence in yellow. The door is also locked to prevent wandering. Individuals that may be performing audits or reviews might not be as adept at understanding what that particular sentence means or says. They might misconstrue this to think that the door is locked and no one can get out. This may be misconstrued to indicate that the individual is locked in a room. So again, another example that I think would be better is an example with person-centered service planning. And so the other additional information that would be nice and could be a sentence would be, the door to exit the ADS requires a keypad code to unlock the door. To prevent wandering, Jane will not have the code. This little bit of information allows us to see a clearer picture that wherever Jane is, there is a locked door. However, it has a keypad. Jane doesn't have the keypad number because we don't want her to be able to exit the room on her own. This may apply to other people if you are talking about a memory care unit, but again, the additional information helps paint the picture so we can see that someone is not being restrained against their will, and that this is not a punishment but a reason to prevent her wandering. Let's move on to the second care plan, which is for Mary Smith. While Mary's caregiver is in recovery, she is in need of a stable plan of care. Mary is in need of HCBS. So again, the HCBS guidelines will be reviewed annually. Mary will attend adult day service 5 days weekly for socialization and to assure her daily safety in the absence of her caregiver. Mary requires no HCBS modifications. Mary will be educated on HCBS modifications annually, and Mary does not take medications at ADS. So the goal is Mary will have a safety plan in place while her caregiver recovers from health complication. Mary will have access to home and community-based services. Let's go to the next slide. All right, on these two examples, we're going to talk about Alice Miller. Alice Miller has a diagnosis of quadriplegia and requires total care. Medicaid state plan. Alice receives PDN nursing Monday through Friday from 2 to 7 p.m. from RNIP Janice Smith. Alice needs help with range of motion, Hoyer lift transfers, suctioning, and wound care. The PDN nurse, Janice Smith, is approved and authorized for 25 hours per week. So again, it's all laid out. Something to point out in case you're not familiar with PDN nursing, or as you grow familiar with PDN nursing. PDN nursing is actually a state plan service. It is nursing that exceeds the increment of 4 hours of care. So it's 4 hours of care plus would be an assigned nursing shift. Also, within certain guidelines, the PDN nurses can also be individual providers. So in this case, Janice Smith is a PDN individual provider. So the intervention is CM will share the PCSP with the individual and the assigned provider, Janice Smith, who is the RNIP. Janice will bring all required nursing supplies. She will work with Alice daily and provide Alice with updates. The care plan from April 1st, 2023 to October 31st, 2023 has been sent to Janice for signatures on July 8th, 2023. As of August 8th, 2023, the CM has not received Janice's signature back on a care plan. Email sent to Janice on August 8th, 2023, requesting a signature on a copy of the care plan with a return request date included. Alice, as the goal, will have all of her nursing needs met during her PDN nursing hours. Alice's health will remain stable without decline, allowing Alice to remain in the community per her choice. So as we talked about earlier in the slideshow, that not only is this going to be a care plan, it would also be a service line in the service line report. It would indicate that the individual, the Alice Miller, has 25 hours a week of PDN nursing, and Janice Smith is the assigned nurse, and it would indicate any information about authorization and days of authorization, so that this way Alice's provider, Janice, will get paid, and in future audits there shouldn't be any issue or concerns regarding payment. So let's look at the next care plan. Dorothy Evans. Dorothy actively participates in developing her service plan with PAA case manager. Dorothy has requested that her daughter Karen participate in quarterly visits with the case manager. So the intervention is the case manager will visit Dorothy quarterly to ensure service needs and individual preferences are being met. Dorothy has case manager contact information and has been educated to contact case manager if there's a change in her needs or preferences. I like how it says needs or preferences, because sometimes people may not have a physical need, but maybe they've changed their mind about how they would like something to work for them. It just makes it nice to include that so that we can see that this is not cut and dry, that it's all about her needs without her input. So then we go on to the goal, where it's quarterly CM visits to assist with person-centered planning. So that looks good too. Let's see. Let's go to the next slide. All right. This is the last slide with care plan examples. Yvonne has the right to a person-centered care plan that clearly reflects individual goals. So again, under the intervention, it has care plan reviewed and up to dates with April 22nd, 2020, March 26, 2021, May 21, 2021, August 8th, 2022, Yvonne signed care plan page dated 8/8/22 and returned on 8/15/2022. So This is a good care plan, and then this would also, as we spoke about earlier in the slideshow, correspond with that documentation piece of paper that the individual is signing with the appropriate updates and days of updates and check-ins. Let's go to another care plan for Yvonne. HCBS setting rules. Yvonne attends ADS and requires modification to the rule due to aggressive behaviors related to her diagnosis of Lewy body dementia. Less restrictive interventions have not met Yvonne's safety needs, and she has had a past of incident of aggression towards another resident. Okay, so then we want to go over and we want to look at the interventions. So again, it says that they are reviewing annually. The CM will share the person-centered care plan with the adult day service. Personal belongings kept secured in office per agreement if needed, but she brings her own walker now, and she sits away from the residents she had had an altercation with. Extra attention is given due to behavioral concerns. DON, which is the Director of Nursing, to advise of any concerns. ADS is specialized center for dementia clients and appropriate supervision provided. So again, all that description is very helpful. And lastly, the goal is Yvonne will have supervision while at ADS as a modification to the HCBS settings rule to ensure her health and safety needs are met. She will have the least restrictive environment possible while at ADS. So again, this entire care plan and the three components are providing consistent information, and they all agree with each other. So that is why these are good examples. So thank you very much for your attention. We appreciate your help. Goodbye.